Thank you, Boris. Thank you, everybody. Renato, I was not aware of your presentation, but what you said in the end is completely in line with what I'm going to show you now. Okay, so that's my disclosures. You can agree if you go through our main textbooks regarding reproductive endocrinology, you will see that all our teachers, all our estimated authors and senior professors, they concluded that folliculogenesis, ovarian folliculogenesis, may be divided into two different phases. The first one, which is gonadotrophin independent, and the other one, which is gonadotrophin dependent. Well, but in reality, if you spend some time on literature, you can find many articles in which authors have consistently reported that FSH and LH receptor may be expressed onto granulosa cells, even at very early stages of folliculogenesis. And this morning, Francesca clearly showed this, clearly confirmed this, and ourselves, Francesca Liuzzi and Serena De Carlini from our own lab could confirm this. Sometimes it depends on what kind of receptor are you using, what kind of antibody are you using, what kind of technique are you using, but still you can find some receptors for gonadotrophins at very early stages. Of course, the rate of expression of those receptors is increasing across folliculogenesis. This is to say that large follicles for sure will express a higher quantity of receptors when compared to very small follicles. And we have here some experiments in vivo, in vitro. We have here mice ovarian follicles, very small ovarian follicles, which have been cultured with gonadotrophins. And you see here, FSH was able to keep growing these follicles. And what's interesting here is that when the LH was added to the FSH culture, then you had a higher proportion of follicles, of very small follicles, reaching the antral stage. And in the same article, authors have reported some information on the quality, on the morphology of the follicle. If just LH was added, then you had healthy cells, but you see here there's no antrum. On the contrary, if you are adding just FSH, you have the antrum, but the oocyte is degenerated. The best solution is when you give both the two gonadotrophins. And we know that LH is very important for follicular growth, as it is inducing and promoting the synthesis of growth factors and androgens, and we heard how much androgens are important and relevant. And very recently, our lab is demonstrating, working with Casarini team, is demonstrating that LH has something to do with AMH2. In particular, the LH treatment of granulosa cells induced a downregulation of the AMH receptor type 2. And you remember from this morning that AMH has an inhibiting effect onto folliculogenesis. And we also found that AMH downregulation induced by LH prevents the AMH, the activation of the AMH downstreaming signaling. So that's very intriguing, because this morning some of other colleagues have shown some relationship between LH and the AMH and the AMH receptor. That's quite interesting, I think. But now let's move from the lab to the clinical side of the story, to the patients. Can we investigate ovarian folliculogenesis in patients in vivo? Yes, we can in some way by measuring the AMH, which is again produced by the small antral follicles within the ovaries and then secreted into the blood, or you can count with your own eyes the small antral follicles by using the ultrasound machine. Now, the hypothesis here is that we have two women, two 25 years old women with the same number of primordial follicles. However, the rate of progression of primordial follicles to the stage of antral follicles may be different in these two patients, so that this lady will have an AMH of 3, 15 antral follicles within the ovaries. On the other side, you have a woman with 0.5 AMH and with 5 antral follicles, but they have the same number of primordial follicles. And they will experience menopause at the same age because the number of primordial follicles is the same. Is this hypothesis feasible? Well, let's look at what we have, what nature gives us. We have some conditions such as hypogonadotropic hypogonadism, which is that condition in women who have amenorrhea and very low LH and FSH. Well, if you go through literature, you can find articles which report for those women an AMH, a mean AMH levels, which is not different from normal women. However, if you go in depth in the results section, you can see that sometimes some women with hypothalamic amenorrhea, they have very low AMH concentrations despite their young age. And again, this is consistent through the articles. You see here, women with hypothalamic amenorrhea, the mean AMH levels are the same, but some women, they had 0 or almost undetectable AMH. The same is true in this article, and the same is true in this article. Serum AMH below 1 nanogram ml in 6 out 16 women with hypo. Another condition associated to hypogonadotropinemia is pregnancy. Have you ever measured FSH and LH in pregnant women? No, of course, because there's no rule to do that, but I did it. And FSH and LH are completely suppressed, almost undetectable. Why this? Because estradiol and progesterone, they are very high into the blood, and they suppress the pituitary, the hypothalamus pituitary. What about the AMH? The AMH is decreased by 50%. Why should AMH decrease during pregnancy? It's possible that the low gonadotrophins may in some way lead to an under-ovarian stimulation. Another condition associated to low gonadotrophin levels is contraception. Sorry, before contraception, the use of GnRH agonist. Long-term GnRH agonist treatment, which is the best treatment for young patients with precocious puberty. And you see here, at the beginning, boys and girls, girls here have very high gonadotrophins, but then during GnRH agonist treatment, FSH and LH are almost undetectable, and after suspension of the GnRH agonist, FSH and LH, again, went up. What about MH? MH went down by 50% during the long GnRH agonist treatment. The same decrease we found in pregnancy, 50% decrease when LH and FSH are suppressed. And what about hormonal contraception? In women under hormonal contraception, AMH is decreased. Very nice, this study, which reported a 31% decrease in AMH in women under pill, a decrease in 29% in the number of antral follicle, and a decrease in 56% in ovarian volume. I very much like this article because this is a prospective study in which women under the pill were investigated. They stopped the pill and they were followed up for 2 to 3 months. And expectedly, FSH and LH, they came back to normal values in just 1 week after suspension of the pill. What about the AMH? AMH increased by 53% in 2 months, as well as the antral follicle count increased by 41%. Can we change the functional ovarian reserve of our women? Let's go back to woman with a hypo. This is a young lady with secondary amenorrhea, functional hypothalamic amenorrhea. So she has low antral follicle count and low AMH because the hypothalamic amenorrhea is a long-lasting condition. But this lady needs an IVF cycle because of male factor of infertility. Of course, you will propose for maximal ovarian stimulation, but how many eggs you will retrieve? Few eggs, because the antral follicle count is poor, is low. Extended LH administration. We have proposed this protocol, this strategy, in order to possibly increase the number of antral follicles in women with hypothalamic amenorrhea. Case number 1, 24 years old, secondary amenorrhea. The LH was 1.2, the FSH was 2.3, the MH was 1.3. Male factor of infertility, she was addressed to IVF. Maximal ovarian stimulation, just few follicles, expectedly, I would say, 3 mature oocytes, 3 were inseminated, 1 embryo transferred, no pregnancy. Before moving to the second IVF cycle, we gave to this lady 150 units of recombinant LH every other day for 2 months. After 2 months, in reality, we check the hormones every 2 weeks, as well as ultrasound. She remained in amenorrhea during the 2 months of LH treatment, no side effects at all. And after 2 months, the MH was 2.3 nanogram ml. So the antral follicle count was 14. And the second IVF cycles was run, and again, the same protocol as in the first one. This time we had 8 mature oocytes, 2 blastocysts, 1 pregnancy. We had another case, 31 years old, was the woman, secondary amenorrhea. The LH was very suppressed, 0.5. The antral follicle count was low. Just before moving to the IVF, we treated this lady with 187.5 units recombinant LH every day for 35 days. Then after 35 days, the patient was tired. She wanted to stop the treatment, but we were satisfied. The MH was 1.6. The IVF cycle was started, maximal ovarian stimulation, 6M2, blastocysts, 3 blastocysts, and 1 pregnancy. And you see here the 2 patients and how the antral follicle count and the AMH moved, increased under the extended LH administration. So we wished to change the dogma here. I mean, in this article, we said ovarian folliculogenesis is just one phase, one gonadotrophin-dependent phase. The point here is that the degree of the dependency is changing. It is very low at very early stages, and then it increases across folliculogenesis. I understand this is highly provocative, but we are here for this. Do we have some independent evidence? That's a French study recently published, in which women with hypothalamic amenorrhea have been treated with a pulsatile GnRH. And you see here, you have here the AMH, which was 1.69 nanogram ml at baseline, and after 3 months of pulsatile GnRH, it was 2.02, statistically significant different. This is an independent group. One group from Denmark has recently published on human reproduction an article in which they tested small doses of HCG. They investigated 20 patients, poor responder, Bologna poor responder patients. So you may agree the worst patient to be treated with new strategies, but anyway, patients underwent a first IVF cycles, then they were treated with a dose of 260 units HCG for 60 days. And then the IVF cycle was repeated. The main objective of this study, the primary outcome, this was a prospective study, was the fourth. And they found no significant difference in the fourth. But what is the fourth again? The fourth is a marker created by that gentleman. And the fourth is the relationship between leading follicles and the number of antral follicles. So you may agree the fourth is investigating just the last 2 weeks of folliculogenesis. Our objective should be the number of antral follicles and not the fourth. But let's read the article. You have secondary outcomes reported by the authors, and they showed that there was a significant increase into the number of antral follicles in Bologna poor responder, who are the worst patients when talking about new strategies, an increase from 4.7 to 7.3, a statistically significant increase into the number of eggs from 3.2 to 4.7. With this, I don't want to say that this is conclusive, but in some way you may agree this goes in that direction. Now, what is normal LH reference values? What are the normal LH reference values in the general population? Difficult to say. We have not so many studies on that. But we were able to retrieve data, and the median LH value is 5.9, the fifth centile is 2.4, and the 95th centile is 12.6 units. Now, on the left side of the LH distribution, you have women with hypothalamic amenorrhea. Who is there? Who is on the right side? PCOS. Okay. Again, can you see some relationship between the number of antral follicle and the LH? You have here high LH and a high number of antral follicles. You have here low LH and low number of antral follicles. And what about this population? Can we think that women with a lower than median value of LH, in reality, they live with a relative depletion? Can we hypothesize that those women are not exploiting totally their ovarian reserve? That's our hypothesis, which was the basis for this ongoing randomized control trial. This is a phase 2 randomized control trial, multicentric randomized control trial. Modena is the main center. Then we have Turin and Milan. And the objective here is to demonstrate, if possible, an increase into AMH levels after 2 months of 187.5 units LH daily in women who have low LH, lower than median value. So I hope that next year, when we hopefully will repeat this Congress, this meeting, we can deliver some preliminary results. What Renato said, I mean, I fully agree with what you said. And I'm going to show you why. We now have the duostim. The duostim is made of 2 back-to-back ovarian stimulation. So the standard IVF is consists of administration of FSH for 9 days, 10 days, 11 days. Then the duostim came, which is made of 22, 24 days of FSH stimulation. Is this long exposure to FSH made this lead to modification in ovarian folliculogenesis? I don't know, but what I can show you, Renato, is this article, which we have published on human reproduction last year. This is the number of retrieved oocytes after the first cycle and after the second cycle. And we found an increase, a trend for 30% more oocytes in the second simulation, which has been reported also by other groups such as Subaldi and other colleagues. And so this was our hypothesis at the time. I mean, this is the very well-known figure published by Bart Fauser and Nick Macklin on endocrine reviews many years ago. And this is probably a possible modification according to what you are saying too. The long exposure to FSH may save in some way a higher rate of small secondary follicles. So let me conclude. Some in vitro evidence support a facilitating role of LH into the progression of follicles to the antral stage, which could indicate that in the absence of LH, there may be a reduction into the pool of antral follicles. Hypo is a good in vivo model for understanding the role of gonadotrophin depletion on ovarian function. Patients with a long-lasting and deep suppression of gonadotrophin secretion may have very low AMH and antral follicle count. Even if limited to a few cases, the extended LH administration, which we call the ELA, seems to be associated with an increase into the number of antral follicles, as shown by an increase in AMH and the AFC. This protocol may permit to increase the number of retrieved oocytes in hypo patients per stimulated cycle. We are now testing the hypothesis that all women with a relative LH deficiency, which could be LH below the median value, may benefit from the ELA protocol in terms of a possible increase into the number of recruitable follicles at the time of ovarian stimulation. Finally, since we have so many young researchers here, I want to inform you that Minerva Obstetrics and Gynecology, I'm the editor-in-chief of this journal, gained a good impact factor. I think in the last year it was 1.6. So now, Boris and Carlo, your best research is more than welcome. I will treat your articles very kindly. Thank you very much.